Welcome back. Now we have a panoramic radiography review. And again, this isn't meant for first year dental students. This course is meant for second years and just a review of things that you've already learned. So I go very quickly over panoramic geometry. I go into panoramic anatomy fairly quickly, and then just a review of positioning and quality errors. So panoramic imaging you have to think of as taking a three-dimensional object, which is relatively spherical. None of us have spherical skulls, but relatively spherical, and trying to map that onto a two-dimensional image. So just like taking a map of the globe and trying to put that on a two-dimensional map. That's what we're trying to do here. And so what do you know about two-dimensional maps that display the entire world? Greenland, is it really that size in relation to the United States and to other things? Antarctica, what's it doing down here? It's just kind of stretched out across the entire world. Nobody knows what Antarctica looks like, right? And so the same thing happens with panoramic imaging. Scary background music there. So it's just like you're taking the skull and you're just stretching it out. And so when you're looking in the middle of the image, it's like you're looking at someone from the front. When you're looking toward the back, it's more like you're looking from the side. The idea is to open up these contacts. And so ideally it's going to follow that curvature of the mouth. But as you get further and further back, it's actually looking more from the posterior. So if you imagine that kind of being stretched out wide, a lot of times the lateral pole of the condyle is going to be projected where it looks like it's more medial. If you think of it as the image being stretched out so much, or the X-ray projection coming so much like it's from behind, you can imagine the lateral pole being projected more toward the medial. That's something I think a lot of people overlook. And so here we have that stretched out skull, and then what it looks like in a two-dimensional X-ray, which is our panoramic radiograph. And we see all of the maxillofacial complex. We even see the orbits here. Hopefully you do see the temporomandibular joints. And of course all of the dentition. It seems rare that you actually do get open contacts. You always tend to see some degree of overlap. But this image does a pretty good job of showing all the dentition. They're within focus, so they're within the focal trough. And we'll talk a little bit about that, how that works. And so I've summed this up into just 3 overall principles that you need to know. Really trying to simplify it. Maybe it oversimplifies it, but maybe you don't have to understand every single geometric principle to understand how panoramic radiography works, at least to the point where you can interpret what's going on. And so these 3 principles, the first one, you probably remember, focal trough. Only things within the center of that focal trough that follow the curve of the dentition, the curve of the mouth around, are going to be in focus. Other things are going to be stretched out, they're going to be blurred, and you're not going to see them as well. The second principle is lingual objects. The X-rays come from below. What that means is an object that's closer to the source of the X-ray is going to be projected upward relative to other things. Think of it as something on my tongue. If the X-rays are coming from below and going up through my skull, something on my tongue is projected upward in kind of an upward angle. So it's going to be projected superior from where it really lies in relation to maybe where it overlaps the teeth. Third principle will be ghost image. Hopefully you understand ghost image. Real image is an image that's taken between the point of rotation and the sensor plate. And a ghost image is just the opposite of that. And so on the other side of the point of rotation, between the point of rotation and the source, the X-ray source, if there's something in that area, that projects a ghost image onto the other side. So it's projected on the other side, it's projected higher. Again, that kind of relates to principle 2. X-rays coming from below, so that it comes all the way from the other side, it's projected higher on the other side and to the opposite side. One way to remember that is ghosts float. So ghost images should be projected higher when you see them on the other side. All right, so now we're getting down into the details of the first principles, the focal trough. So you have this moving point of rotation. Hopefully you remember that about the geometry of panoramic radiographs. That you have the source on one side, the X-ray. Can't see my hand there. The X-ray coming from this side. The sensor is on the other side, and both of them move kind of in sync, but in opposite directions around the patient. And so that moving source generate a zone of sharpness. They move in such a way where the only things that move in the same the same speed, I guess I would say, in relation from the X-ray to where the sensor is where you want that focal trough. And so you can kind of change the timing, change the speed of how it moves around to choose your focal trough. And these machines are designed to try to create a point of focus that follows the teeth around there. And so anything outside of that focal trough, let me get my pointer up again, whether it's toward the lingual or the buccal, it's going to be more blurred. And we'll talk, the next principle we'll talk about whether that causes magnification or shrinking of the object. But just know for now that the moving source and receptor generate that zone of unsharpness. The closer it is to the center of it, the more in focus it'll be. Also, the more accurate spatial proportions that you'll have. And so that's why it's important that the patient is lined up correctly. They should be lined up with their dentition in the focal trough. And, you know, people have different shaped jaws. Some people have large jaws, some people have others that have smaller jaws. And that's why you have these different settings you can choose on a panoramic machine to hopefully tailor it to your patient. Okay, now I want to talk a little bit about image magnification as promised. Might take you a minute to recognize what's going on in this GIF here. What are these? These are hand puppets. And so this is projection geometry, and radiology is all about projection geometry. So the principles that apply to these hand puppets apply to radiology. How is it that some of these, you know, they're making people with their hands, a lot more talented than I am, but how is it that some of them are larger than others? You know, some are out of focus, some are more in focus. If they're closer to the source, the light source in this case is going to be magnified, right? The closer you are to the source that's projecting it onto the wall. So if you think of the source in this case as the X-ray unit and the wall as the sensor, you can think of just the same principles that you do in projection radiography. And so I'll talk a little bit about divergence from the source versus divergence from the center of rotation. If we're just talking about projection geometry on a two-dimensional image, then whether we're talking about horizontal or vertical, you get the same magnification, right? I move closer to that source, everything's magnified in the same proportions. Horizontal, vertical, it doesn't matter. But panoramic radiography is a little bit different because, yeah, the X-rays are coming from a point source, but it's collimated vertically. And so you have this vertically collimated beam. And as I said, it's coming from behind the patient, kind of projects up like this. And so in a vertical dimension, that magnification is based on the source point and the distance from the source point. Think of a pano, and the source is way back here as it's going behind a patient. And how is it different for a horizontal? So I said it's vertically collimated, but it rotates around the patient. And so that horizontal spread isn't from the divergence from the X-ray beam. The horizontal spread is from rotation of the X-ray beam. And these machines are set up so that point of rotation is kind of in the center of the patient's head. We'll show you how there's a moving point of rotation. It moves in a V. So as it's moving around the patient, that point of rotation is actually moving. And so let me ask you this thought question. So which is going to be more magnified? Is it going to be in the vertical dimension, which comes from the point source? Or is it going to be from the horizontal dimension, which that magnification comes from that point of rotation, which is a lot closer? Because that point of rotation is a lot closer to the object you're imaging, your horizontal magnification is going to be exaggerated. And so that's what I mean here by the difference of a divergence from the source versus divergence from the center of rotation. All right, stick with me here. This still has to do with the first principle. That first principle is the focal trough, that only those things in that focal trough are in focus. And now we're going to talk about distortion, and that's different whether we're talking about the horizontal or vertical, like I just alluded to. Now these images do a really good job of explaining this if you can make sense of it. These are from the White and Farrell book. And so looking at image A and B. Image A, so this is the radiograph taken with it positioned in that position. Where is the patient biting? Where is this mandible lined up? It's in where it should be, in the focal trough. It's in that notch where it should be. And so this metallic ring is lined up roughly within the focal trough. And so you should expect proper proportions, you know, more or less as good as we can hope for from a panoramic at least. And it should appear relatively circular, which it does. And it's in focus, not very blurred. So that's what you expect if it's properly positioned. Now C and D, so this shows the resulting radiograph in D if you line it up as C. How is this positioned? The patient is lined up too far back. The mandible is posterior, and that brings this object more lingual, right? More toward the lingual, more toward that point of rotation. So I said magnification is exaggerated in the horizontal. If magnification is exaggerated horizontally, if I move it back, think of that GIF I just showed you, something closer to the point source, the source of light, is going to be magnified. Being exaggerated in the horizontal dimension, it creates an ovalic, is that a word? An oval appearance. It's really just stretched out, but it's magnified more in the horizontal direction. You can see the same thing with the teeth. They're stretched out horizontally. They're blurred because they're not in the focal trough. So no good, right? But you can tell from this, you can tell from the shape of the teeth, now ignore the ring for a second, that this patient was aligned with the jaw way too far back, not in that bite notch where it should have been. So lingual to the focal trough. E and F now, where are they biting? Too far forward. That's when you put your patient in there, maybe didn't use the bite notch correctly, the patient's biting way far in front of it. And what happens, remember we said it's exaggerated in a horizontal direction. And in this case, because a panoramic is just calibrated to keep things properly proportioned when it's in the focal trough, if something's too far forward, it can actually shrink. And so in that regard, it's a little bit different from just two-dimensional projection, but it has to do with creating that focal trough. If we're too far forward, it's no longer proportioned. It's closer to the sensor. The sensor's in front of the patient when you're imaging the front. Being closer to the sensor, shrunken down horizontally. It also becomes a little bit blurred. Now look at the teeth. Compare these ones. These teeth are shrunken horizontally. I can tell that the patient is biting way too far in front. And so because of all these distortions, because things are not perfectly proportioned, we know the panoramic is not reliable for measurements. When people do measurements, usually they'll have some bead, some metallic BB or some type of bead, where they know the dimensions of that bead, and then they can calibrate the dimensions of whatever they want to be more accurate. All right, now hopefully that all made sense, and if it did, I'm going to test you on it. So here's a thought question for you. An object positioned closer to the point of rotation, how's that going to appear? If something's positioned closer to the point of rotation, where is that? More toward the lingual? More kind of toward the inside? It should be magnified. Think closer to the point of rotation. Closer, it's similar to being closer to the source. And so it's going to be magnified, but exaggerated in the horizontal dimension. And so stretched out horizontally. That's our C and D here, closer to the point of rotation. And conversely, object positioned closer to the sensor is going to appear how? Closer to the sensor, I said it's a little bit different than just 2D projection, where if you're actually outside that focal trough, if you're buccal to the focal trough, closer to the sensor, it loses its proportion and it gets shrunk down, exaggerated in the horizontal dimension, so it gets shrunk down horizontally more than vertically. And that's the appearance you get right there. Hopefully that made sense. And if that makes sense, you can make sense of when you see images that look like this. Look at the front teeth. That's how you really tell if the patient's positioned properly in the anterior. In this case, which teeth appear horizontally magnified? Compare right to left. This is how you look for rotation of the patient, so head rotation like this. The side that's magnified should be what? Closer to the point of rotation or closer to the sensor? If it's magnified, magnification is closer to the point of rotation. So the right side was closer to the point of rotation. This is the left side. I just said that wrong deliberately so that you can learn. We always talk about the patient's left. That was not deliberate, I'm kidding. We can talk about the patient's left when I point on the right side of the image. That's always going to be the case in radiology. Patient's right is always on our left side. So I'm going to call this the right, this the left, just so we're always clear about that. Okay, this is the left side. It's magnified horizontally. It's closer to the point of rotation. This is the right side. It's shrunken horizontally. It's moved closer to the sensor. Which way are they rotated? And one way you can tell is this black line here was put right in the center, right in the middle of this image. I mean, you can tell looking at that they're rotated with their head to the right. Does that make sense with what we're seeing here? Let's double check that. Head to the right, I said the left teeth are stretched out. They're closer to the point of rotation. If I moved like this, yeah, my whole left side gets closer to that point of rotation. And my right side goes the opposite way. It gets further from the point of rotation, closer to where the sensor is, which is over here when I'm imaging the right side. And so this is head rotated to the right. Hopefully that makes sense. It does get a little tricky because you can have head rotation with the anterior teeth still right in the center. So imagine this is the center and I can still rotate my head. And then if you pay attention to the back, so this we said was rotated right. But if I had my midline lined up correctly, where that's right in the center, and I rotate my head to the right, look at my back teeth. They're actually going the opposite direction because I'm rotating kind of more from the front. So my right teeth came more closer to the sensor, which means they should be what? Magnified, or left teeth, sorry. My left teeth closer to the sensor, they should be what? They're closer to the sensor, they should be shrunken. So it'll actually look opposite of this. And so you do need to look at that midline, that center line. If it's off like this, that is kind of a dead giveaway, but if it's on, then you kind of have to do that in your mind. Think, okay, head rotation. I have this right in the midline. If I move my head this way, my left teeth came closer to the sensor. They should be shrunken. Hopefully that's making sense, but at least, at the very least, just be able to recognize when there's rotation, know how to fix it, know how to align the patient properly in the panoramic radiograph, know how to recognize it and tell someone, hey, the patient's head was turned one way or the other. So what is a ghost image? And again, this is kind of a shortened presentation where I didn't go over what a real image. So really quickly, real image is the opposite of what you see here. It's between the source and the sensor. Maybe I need to explain what these images mean. So if you can tell here, it looks like you're looking down on a mandible. Usually in radiology, it's the other way around. It's when we're looking at axial slices, it's if you're looking up at the patient. But in this case, you're looking down on the patient. So this is the patient's right side. This is the patient's left side. And this is the start of an image. It starts with the X-ray source in front of a patient, kind of coming back like this, and the sensor is behind the patient on this side. And they're imaging the left side. So they're imaging the side where the sensor is closer to. So that's what it's showing right here. This is the sensor. And so this is how it starts, and it starts rotating around. And when it starts, this is the point of rotation. As it's moving around, that point of rotation moves in this V shape. So each of these little dots represents that moving point of rotation. So that's the start of the image. And then it continues around like this, and this shows halfway through the image. So once it gets to that point, I said starting here, sensor behind me. This is the X-ray source. They both move around like this, and now we're in the center of the image. Sensor right in front of the patient's face. That's what we're looking at right here in B. So X-ray source behind it. The point of rotation has moved toward the midline. As you would expect, doing the anterior, that point of rotation should be right in the center. You want to open up those anterior contacts. And then C is showing as it continues around. So not quite making a 360-degree loop, but now we're finishing up that loop and we're imaging the right side. Now we have our point source, our X-ray source on the left side of the patient. Here's my sensor coming around here, getting my right teeth, and my right TMJ is the last thing that I get. And so that's what that's showing. And so what is the real image? I said you start like this, X-ray unit on the X-ray source on the right side. You're capturing the left TMJ as one of the first things you see. Then you start imaging the teeth. This point of rotation is moving, so ideally you get open contacts. It continues moving, you get open contacts in the anterior, that's what's showing B, and then same thing on the other side. So anything between the point of rotation and the sensor plate is a real image. That's where your focal trough is. That's creating that real nice focal image, and that's what we want to see. Everything else hopefully is blurred to where we can recognize these structures. And so a ghost image is just the opposite. It's between the source and the center of rotation. So as you're starting the image, what are you going to see a ghost image of? What's between the source and the center of rotation? Anything here? You actually see, in most cases of panoramic radiography, you see a ghost image of the opposing mandible. And we'll show you that. It's kind of stretched out across the other side. It's higher. Remember, ghosts float. Ghosts should always be higher than the real object. What do you see a ghost image of here when it's imaging the middle of the patient, crossing through here? You see a ghost image of the spine, to some degree the hyoid bone, but you'll also see a real image of the hyoid bone over here. Yeah, the spine and hyoid bone, most of the time ghost images are going to be blurred beyond recognition, so that's that white blur that you just see in a panoramic radiograph across the midline, and it affects the mandible mostly. And then over here, just the opposite. You get a ghost image of the left mandible projected onto the right side of the image. And so this orange just fills in everywhere in this patient where you might see a ghost image. Okay, so the posterior mandible, usually not the teeth though, right? In most cases, you're not going to see a ghost image of a teeth, but there are a few cases when you can. Where would a tooth have to be to create a ghost image? Really lingually inclined, very far posterior. And so we'll show you some examples of ghost images of teeth. All right, thought question for you now. Which areas create ghost images in a panoramic radiograph? NDB ramus, check. We talked about that. That's in that orange area. Does the anterior mandible ever create a ghost image? I've never seen that. So no. Does the spine? Yeah, when it's coming from behind, you see the ghost image of the spine. If I go back here for a second, no, I can't do that. But when it's starting the image, when you're starting the image, the TMJ, you're also, in a lot of cases, if the patient's far forward enough and not too big, you're going to see a real image of the spine, right? Between the point source, or the point of rotation, and the sensor. And so you get a real image of the spine on either side. You get a real image of the TMJ on either side. You get a ghost image of the mandible that just looks kind of like a blurred streak projecting to the other side. All right, which tooth position is most likely to create a ghost image, A or B? Buccal posterior or lingual posterior? More likely toward the lingual, right? Then it's more likely to cross this line where it could be between the point of rotation and the X-ray source. All right, this was a case where someone was doing a surgery, extracted a third molar. Hey, they got it out, but then they lost it. Weren't sure if they swallowed it. It kind of disappeared. They took a panoramic radiograph. And here's the tooth. Way back here. Is this toward the buccal or lingual? What do we see on the opposite side? Do we see a ghost image of it? Yeah, right there. We said ghost images should be blurred. A lot of times they're stretched out like this. So this is a ghost image of that extracted third molar. And I used to talk about that as, yeah, it's probably more likely to be toward the lingual, but seeing as we see a ghost image of the entire mandible, and this is pretty close to the mandible, which it should be, it could be buccal or lingual, and I'm not really sure. You know, depending on how they did their incision, it's more than likely going to be toward the lingual. So maybe a better example is this next one. Looking at a ghost image here. How do we know that's a ghost image? The provider took this panoramic radiograph and they were worried about something in the sinus. They did a lateral cephalometric. Is there anything in the sinus there? No, so excluded that. And so what's creating this? What is this a ghost image of? I said we don't normally see ghost images of teeth. Let's look at the other side. You got wisdom teeth here, third molar way back here. Do you think that third molar is buccally or lingually inclined on the patient? And how do you tell? Well, what did we say about that horizontal magnification? If something is more magnified horizontally, this looks a little bit stretched out horizontally compared to the second molar. You know, the first molar should be the largest tooth, but this third molar looks even larger than the third molar. That's telling me likely that's stretched out horizontally. So is that what, palatal or buccally inclined? It's closer to that point of rotation because it's magnified. It's more toward the palate. So a very palatally inclined third molar. Is that the position you would expect more likely to create a ghost image on the other side? Yeah. Very far back, inclined pretty far palatally. Maybe they had a little head rotation. Doesn't look like much in this case. But sometimes head rotation can help create ghost images of teeth because you rotate the head and it goes so far lingual that it can get in that zone where it creates a ghost image. And so yeah, that's just a ghost image of a tooth. Why is it so opaque here? Well, that's that big filling. Big amalgam filling, very opaque, really stretched out horizontally because it's really sitting right on that point of rotation as it's going through. So it creates a lot of horizontal stretch. And so that solves that mystery. That was a great example. All right, what's going on here? Someone got shot by a shotgun. All right, here's what shotgun pellets look like. It almost even looks like that here as it's coming out of the wad there. And so how do we explain that? What is the real image of the shotgun pellets and which are the ghost images? Real images more likely to be in that focal trough and in focus, ghost images stretched out. And so the left side here, what we're seeing on the left side or overlapping the patient's left side is ghost images of all these pellets over here. And yeah, maybe they have some scatter, some real ones, or maybe these are just projected in a way that they are real or that they stay in focus. But yeah, largely you can say the damage is done here. Obviously on the right side, very in focus, nice round pellets for the most part. Some of them looks like broke apart, got a little debris. Maybe some of that is amalgam fragments, but no fun for. All right, now let's get to our brief review of panoramic anatomy. Not going to go into too much detail. You know, a lot of anatomy is just memorization, and so you've got to spend the time going over the books. And I gave you links to the different chapters from different books. All of those chapters I think are great. Do a good job of panoramic and intraoral anatomy. All right, so let's start with some maxillary structures here. Before I bring up what it is, I want you to have a look at it and see if you can name it. So we're pointing to this inverted teardrop shape, well defined, you know, cortices around it. Where is that? That's on the posterior aspect of the maxilla. You follow the tuberosity back, and if you follow that up, that should align with the posterior wall of the maxillary sinus. And so what is this teardrop shape feature, anatomical structure that's posterior to the maxillary sinus? Well, that's the pterygomaxillary fissure. And here we see on a dry skull what it looks like. What is this entire fossa called? The pterygopalatine fossa. And I wouldn't have a problem calling it either, but really we're thinking, okay, where do these x-rays come tangentially there to where it's creating this corticated appearance? And we call that the pterygomaxillary fissure, the fissure just the opening to that fossa region. Here it is in an axial slice on a cone beam CT, showing how this is really the part of it you see, and then the arrow pointing into where the fossa is. All right, what do we have here? What are these horizontal lines? Why are there two of them? Is that normal? Does this patient have some problem? So you'll see this a lot, right? And which one is the real image? The inferior one or the superior one? And so this is just the hard palate line. You think of, you know, the floor of the nasal cavity, it comes back here. The floor of the nasal cavity and the hard palate are basically the same bone. We said ghosts float. And so the white one, the superior one, is the ghost from the opposite side. So you kind of get it running tangential both to the left and right side, and you get this corticated appearance. It's a little bit blurred, a little bit stretched out, but more stretched out horizontally, and it's a horizontal line, so that's why it looks as clear as it does. But the black is the real image of the left side, and then the white, or the superior one, is the ghost image of the right side. So recognize those. This was something to know from intraoral anatomy. In fact, a lot of this stuff is the same. So if you know your intraoral anatomy, panoramic anatomy is going to be fairly easy. And so this creates a radiolucent area inferior to the molar region. What is that? Well, we see it on our mandible here. It's a depression in the bone. What do we call depression in bone? It's a fossa. It's on the lingual surface of the mandibular body. What gland? It doesn't necessarily lie right there, but is associated with that. It's the submandibular gland, so that's the submandibular fossa. Here we see it from a periapical radiograph that shows it really well. So a lot of times really sparse trabeculation through the inferior mandible. Don't always assume that means pathology. All right, these are the structures that everyone should know. You should be able to identify a lot of these anytime you're looking, anytime you're analyzing a panoramic radiograph. And so, I mean, I think back to when I was a general dentist, I didn't really know how to identify most of these, but really you should, and I'll show you why later. I'll kind of start with some of the most important things I think you should know is being able to follow the maxillary sinus line. And I said in intraoral radiography that this is my favorite structure. Is this part of the maxillary sinus, or is it something that just projects over the maxillary sinus? My favorite anatomical structure to know is the zygomatic process of the maxilla here on this side. You can see on the left side it does look like it kind of lines up with the floor of the maxillary sinus, so you may mistake that for the maxillary sinus, but don't make that mistake, right? In this case, it doesn't line up just perfectly. The maxillary sinus continues on further back. And so that was the tip I told you. Follow the tuberosity back, and if you follow the tuberosity up, that should coincide with the posterior border of the maxillary sinus. In this case, you have the third molar there. So here's your tuberosity, and there's the posterior border of the maxillary sinus. And so this line just anterior to that is the zygomatic process. And that kind of goes up and joins with the side of the orbit. So you can find the orbit that way. A little canal that you'll see a lot of times, superimposing the inferior border of the orbit. So that's the infraorbital canal. Here it is on this side. Why do you have this extra line here? Well, this is just a sinus septation. I talked about sinus septation in intraoral. So you'll see that in panoramic as well. But all these structures are here. That looks nice and healthy. Why do you need to identify these? Because the patients can get sinus carcinoma, squamous cell carcinoma of the maxillary sinus. That can destroy borders. If it starts to destroy these things, they show up fairly well on a panoramic radiograph. This is within the focal trough. That's why you see that corticated border so well. So anything that you can see very distinctly, and I guess maybe one of the fortunate things about pano is you don't see a lot of the skull base, at least not in focus. But you will see into the middle cranial fossa. Let's see, while I'm here, I'll point out again, this was that inverted teardrop or pterygomaxillary fissure, which part of that is the posterior border of the maxillary sinus. And then back here you have the sphenoid process. It's part of the sphenoid bone where the pterygoid plates come off, and sometimes you'll see those pterygoid plates. It doesn't show up too well here, but I think I can make a little bit of an outline of the pterygoid plates. All right, study these, know all these, a lot of different examples in the book. I'm not going to painstakingly go through every one in this video. I also know the soft tissue structures, that's what we're seeing here. So we have our panoramic radiograph, and then they've labeled some things. The purple is what? Is the tongue really that big? It just looks ginormous in a pano, right? Because of panoramic geometry, things are stretched out. That tongue sits on that point of rotation for quite some time, and so it just makes the tongue look like it stretches all the way across here. This is all the tongue. They left a little air gap between the tongue and the palate, so we'll call that our palatoglossal airspace. Here's the hard palate line. Sometimes it shows up more distinctly than others. The hard palate, you follow that back, it should connect with the soft palate. So things make sense, right? One thing connects to another. You should know your anatomy. And what's at the bottom of the soft palate? You have the uvula, although that doesn't always stand out very well. This one does coincide, what do they have labeled here? The earlobe. And I've received a lot of questions about earlobes. Students ask, what is this? Because sometimes it stands out as really dense. For some reason, the patient has just dense tissues and it really stands out. In one case, this is the styloid process kind of overlapped the earlobe. It looked like a snake. It really looked like a snake with a tongue coming out of it. And she was confused. She said, what is this? I said, well, your patient is the heir of Slytherin, obviously. So be able to recognize these structures. I won't say they're dumb questions. I'll just leave it as that. But you should know anatomical structures. This also points out some things in the nasal cavity. The turbinates, which again, like the tongue, they're really stretched out and they do go really far back. If you've ever seen someone do a nasal surgery and the surgeon takes out those splints and it's like 5 inches back into their skull. And so they are large structures. It goes a ways back here. It overlaps beyond the maxillary sinus. That's how you know it's not something that's contained to the sinus. And then you see a little gap between the inferior and the middle turbinate. And so I would call this the middle meatus. If you remember, meati are just the spaces in between turbinates, or spaces, the air spaces around the turbinates. And of course, that midline vertical thing in the nasal cavity is the nasal septum. A lot of it is cartilaginous, but then you have the bony part of the nasal septum as well. So we're seeing some of both of that. And look at the airspace. Again, there's nothing on an image that you should just ignore. And so you follow the nasal cavity back, you know, relatively, now we're just kind of looking down here, the relative radiolucencies, because we're looking at air spaces. That nasal airspace leads back above where the soft palate is. Here you have your nasopharynx, and then below the palate line you have your oropharynx. And this doesn't point it out in their image down here, but you can see, what is this? You think of it kind of like the inverse of the uvula. The uvula hangs down, you have this cartilaginous tissue that goes up. This is what helps you swallow and breathe, and hopefully not both at the same time. That's your epiglottis. They've got some somewhat pronounced lingual tonsils here, the base of the tongue. That's where your lingual tonsils are. Sometimes that stands out as really pronounced. Other times it lays flat against the tongue, so you can't really distinctly see the epiglottis. Here we have, is this a soft tissue structure or hard tissue? It has a little bit of a cortical outline around it. So from the last lecture, I talked about having a cortical outline, meaning that something is a bony structure. So that's our hyoid bone. You ever seen someone call this a clavicle? Have you ever called it a clavicle? If you don't, you'll never see a clavicle. Look how far down that is. You'll never see a clavicle on a panoramic radiograph, and if you call that a clavicle, you sound really silly. Hyoid bone is in here. Sometimes it projects over the mandible. All right, a couple arrows here. What are they pointing at? Is this some object in the sinus? Look at the sinus borders. It looks like it should come through here. Probably not a metallic object in the sinus. Why do I say metallic? Just for the sake of how radiopaque it is. That's something metallic. Does it have nice sharp borders, or does it look more like a ghost image? A little bit blurred. Can't really tell on this one, but a lot of times you'll see more of that horizontal stretching, the horizontal magnification, where it's more blurred horizontally. And this is just a ghost image of what? We don't really see anything on the other side. In this case, it's not this big crown, but it's an earring that doesn't show up on the other side in the image because you don't see that far back on the earlobe. And so earring ghost image, just projecting over these things. Always take off earrings, necklaces, anything metallic. Glasses, even plastic glasses like mine, should be removed. Sometimes there's metallic screws, although I will say that's not the biggest deal. What is this arrow pointing to here? We have a jaw fracture? Is this a lecture on fractures or is it on anatomy? There's your hint. This is just a little air gap. So what is creating the air gap? What is this huge thing? That's your tongue, remember, stretched out across the whole pano. You have the palate-glossal air gap here. And back, so here's our soft palate, right? Follow our hard palate back. Back here, that air gap is just very thin. So that's just the palate-glossal air gap on the soft palate, uvula, creating a small radiolucent line. Not a fracture. If you can see it continue onward beyond the bone, that's a sure sign that your radiolucent line is not a fracture. But here it just kind of follows the tongue base. Ooh, here we go, as promised. What do we see here? How do we distinguish from what's going on here? If you look really close, you can kind of see a cortical outline here. Do you remember what the hyoid bone is shaped like? It's kind of a horseshoe. It seems like it curves up a little bit in the back. You have in the center, kind of the center large portion of it, the body of the hyoid, and then those arms that project backward are the greater cornua, the greater horns. And so this is one of the horns of the hyoid bone. Here's the body of the hyoid bone. And what projects over it and kind of curls up like this is the structure I was just talking about, which helps you swallow and breathe and not at the same time, that's your epiglottis. Kind of curling forward, which is common for it. It'll curve forward against the tongue. And so that space between the tongue and epiglottis we'll call the vallecula. That's an area which known for catching fish bones. People go to the emergency room and doctors got to dig stuff out of there. If I look a little closer at this hyoid bone, the greater cornu, I see a little something projecting and stretched across. What gets stretched out horizontally? Ghost images. And so what does this is you have the real image of the hyoid bone. So this is the left side because it's the real image. It's properly proportioned. It's not stretched out horizontally. And then the ghost image of the right side gets projected way out to the side because it's stretched horizontally. What's kind of interesting is it looks like it goes lower than the left side because it kind of curls up. But as it curls up, the part that's being stretched out is a more anterior part. And so sometimes those cross each other. But I like to make sense of everything you can see in a panoramic radiograph. As you can see, this is something else altogether, something that you're not always going to see, but it's not terribly uncommon. This is a calcification of a certain type of cartilage. So what cartilage is below the hyoid bone? The thyroid cartilage. And so that's the superior cornu or superior horn of the thyroid. And it looks like even more, a little bit of calcification here. Anywhere along that membrane you can get calcification. You have your thyrohyoid membrane, but especially along the posterior border, you get the horns. Then in between the greater horn, the superior horn of the thyroid, and the greater horn of the hyoid, there's a small kind of grain shaped, so they call it trapezial, the word for that, piece of cartilage that'll calcify. This looks fairly large compared to your typical trapezial cartilage, but all these, both of these just look like laryngeal cartilage calcification, if you want to keep it simple. So that black arrow is the epiglottis, and we have our calcified thyroid cartilage. When we get to calcifications, we'll talk about how that's different, how that appears different from a calcified carotid artery, because a calcified carotid artery is concerning. They've got to be referred to have their cardiovascular system checked out for risk factors. All right, it seems like an obvious question. Is recognizing anatomy important? Yes or no? Hopefully this displays that. What was that structure? Inverted teardrop should give it away. Inverted teardrop shape. What is this versus this? That's our posterior border of the sinus. It aligns with the posterior of the tuberosity. Is this just a sinus septation, or is it my favorite structure? The zygomatic process of the maxilla. So that first one was the posterior border of the sinus, zygomatic process of the maxilla, inferior border of the sinus. Everything over here looks okay. You see the turbinate, it stands out pretty well on both sides. The orbit, everything looks good. What was that? Inverted teardrop shape. They're a little bit different size and shape, but that's okay. May have to do with just a little rotation. Remember, panoramic distorts things a lot. So coming down from the pterygomaxillary fissure, you have your posterior border of the sinus. Here we have my favorite structure, zygomatic process of the maxilla. What is this yellow arrow? Why is there an extra one? Just a sinus septation? You have this extra line there, and it's very distinct. Maybe you look a little closer at this area. Looks like an extraction site, looks fairly radiolucent. But what's going on there? Or another case here. There's another one where the right side looks fine. Zygomatic process, pterygomaxillary fissure. So posterior border of the sinus, all the borders of the sinus. Fine to have big sinus loculations like this. The sinus continues to grow as we age, continues to pneumatize. Here this part of the sinus looks a little thickened. That's not the sinus, but this bone may just be anatomical variation. This is the pterygoid process. This was the posterior border of the sinus. That looks fine. And then it kind of really thins out here. And where is the sinus? We still have my favorite structure, zygomatic process, orbits. And is this concerning, or should we just ignore it? You know, we're tooth doctors. We don't deal with this type of thing. I don't need to do anything about it. This is a squamous cell carcinoma of the maxillary sinus, which destroyed the borders of the sinus. Very important to recognize, very important to point out, have them get this checked out. Patient should see an ENT without any delay. You know, potentially you could be saving someone's life. So do take this very seriously. That's why I take anatomy so seriously. and always stress it in my courses. Make sure that, if nothing else, my students understand how to recognize dental anatomy in radiographs. And so these are the 30 structures you should be able to identify on any radiograph. I think of this as a good starting point. If you know these, you have a fairly good concept of the different areas of the mouth and the maxillofacial complex that you're going to see in a panoramic radiograph. Now we're going to get to quality and positioning errors. Sometimes I see patients positioned where they must have been like this in the pano machine. They're so just distorted. It makes my eyes hurt to look at those type of radiographs. So we're going to avoid that. This is kind of a quick overview where you can tell how to analyze your panoramic radiograph to see if the proper things are included. So you should see the temporomandibular joints up in this area labeled 5. You should see the whole inferior border of the mandible, the rami. You should see some of the inferior border of the orbits, nasal cavity sinuses up here in segment 3. What is this first thing it says? I like seeing a little bit of a smile line. I tell my students, make your patients happy, but not too happy. If that smile line is too exaggerated and they look like the Joker, the chin was down too far. The smile line flat, yeah, maybe I can deal with, but if you have even a little bit of chin up, the hard palate line covers up the roots, the apices of the maxillary teeth. And that ruins your diagnosis of periapical lesions of the maxilla. So that's why chin up even just a little bit ruins your diagnostic capability. And so a little bit of smile line. Hopefully this is all in a focal trough. Every panoramic radiograph you're going to take is going to have perfectly aligned contacts, right? I don't know if I've ever seen that, but that's the ideal. How's this one look? This, I would say, is an example of a good radiograph. Maybe you'd argue there's a little bit of a Joker smile. Chin was down a little bit. But I would rather that than the other way around, as I was saying. Look at the hard palate line. With the chin down a little bit, the hard palate line gets projected even further away from those roots of the molars. And so I would say this is good to acceptable if you want to get really nitpicky about not being too much of a smile line, too chin down. Everything in focus though. Got my big face over the condyle here, but it would show. You see both condyles, you see all the outlines of the mandible. You see a little bit of real image of the spine. Remember I said you'd see real image of the spine on either side? And ghost image is what you see in the middle, and it's blurred pretty much beyond recognition. Sometimes you'll see like this, probably a gap between some of the vertebrae. Hyoid bone looks like it moved a little bit. That happens when patients swallow. Hyoid bone goes up and down. Usually you see the tongue and palate go with it as well. But that was a good example. This one, pretty similar. This was a good example from one of the books. Again, I would say the chin is down a little bit from what I would prefer, just a little bit of a smile line. Don't make your patients too happy. Just keep them to where they want to keep coming back. But everything else in focus looks pretty good. You got all the mandibles. I could have dealt with a little less spine, but hey, that's okay. Ooh, what's wrong with these ones? This is the Hall of Shame material. Take one of these and we'll have a little poster with your radiograph on it and your picture next to it saying this radiograph was taken by this student. No, we wouldn't do that, would we? So glasses, metallic glasses, earrings. These ghost images are really interesting. One interesting thing about ghost images is it looks like it's not flipped. It's not mirror image. Shouldn't it be mirror image? Because it gets flipped, but it actually gets flipped twice. Once because it's on the other side, and once because it's kind of crossing through the point of rotation the other way. And so you don't see mirror image, but you see like a real representation of that earring. But it's larger, it's stretched out horizontally. This is really stretched out. It's projected way up here. Here, nice earrings. Not so nice for my diagnostic capability. Overlapping sinuses, overlapping the teeth here. In some cases, patients say they just won't remove things. Not sure, is that looks like lip studs rather than tongue studs. You'll see tongue rings, tongue studs, nose ring. Yeah, if possible, have patients remove all of these things. Hearing aids as well, but that shouldn't project over at least our diagnostic area. I wouldn't say that's as crucial as some of these other things. All right, positioning errors. I've highlighted the things that I think are most dead giveaways for whether the patient is positioned too far forward or back, or any of these other things. And we already talked through these things. Too far forward, too far back. If they're far forward, their front teeth are closer to the sensor. They're further away from that point of rotation. They get shrunken, which is exaggerated in the horizontal direction, and so they're shrunken more horizontally. So the anterior teeth are narrowed if they're too far forward, and just the opposite for too far back. Now if my chin's way back like this, my teeth are lingual to where that focal trough is. They get widened because they're stretched out horizontally. What about chin up? I talked about this and why I don't like chin up at all. That's because the hard palate line covers up the apices of the maxillary teeth. And I don't know if you probably call this really bowing downward, but it bows like this, right? That when the hard palate line goes like this, or when they're smiling, their line of occlusion curves down, you know the chin was up. So that should be a fairly easy one. Just the opposite for chin down. Like I said, I can deal with a little bit of downward smile line. That's okay. Tilted, that's pretty easy to tell. You can tell when the pano is tilted. It looks like you would expect. So tilted occlusal plane to the direction that it's tilted. Turned, and I showed you that one already. One side's going to be wider than the other. Can be a little tricky determining which side they've turned. But if you look at the midline, and the midline's way over this way, you know they turn to the right, and vice versa. Slumped, I'll show you an example of what we mean by that. I'll show you what I mean right here. When the patient's head is like this, they can be a turtle with their feet way back outside of the room and their heads trying to reach into that bite notch. They really stretch out their neck. That's slumped. Why is that not good? I can have my chin in the same position, but if my neck comes curved way back like that, that neck is going to get more in the x-rays. And so you're going to create more of a ghost image. So a very opaque ghost image of the spine. That's how you know that someone is slumped. And so I'll test you on these now. What's going on here? Is the chin down a little bit? That's not the primary problem. Yeah, there's a little bit of a smile line. Look at the anterior teeth. And think about what's causing the spine to look that way. I see way too much of the spine. Those are real images. In a lot of cases, the spine looks pretty unfocused, but these are kind of blurred. We see the front teeth, they're narrowed, which means hopefully right away you think too far forward or back. If the teeth are narrowed, they're further away from the point of rotation. They're closer to the sensor. This is too far forward. That's what it looks like, lined up. Here's the bite notch way back here, and they've lined up bitten way over the bite notch. Always use that bite notch. It's there for a purpose. It's there to line up the anterior in the focal trough. All right, this looks like not a real human, but a skull. Not a live human at least. But what's going on with the anterior teeth? Now they're stretched out. You see those anterior teeth either stretched out or shrunken. You think, okay, forward or back. In this case, they're back because things further back create more horizontal magnification. So yeah, this was patient position too far back, probably even more exaggerated than what you see in this example, but see the bite trough right there? And they're biting behind it, or if they're not biting on it at all, you're going to get that appearance. What about this one? Is there a big problem? Pretty flat occlusal plane. I can deal with that as long as there's no downward curved occlusal plane, and as long as the hard palate line doesn't superimpose the roots of the maxillary teeth. So yeah, this one is pretty good. Here we even have some lines drawn for you to make it easy. The occlusal plane is curved up like this. The hard palate line is curved up like this. This is chin up. Chin up makes them sad. Makes me really sad. Why? That's what I tell students. It makes me sad because now you can't diagnose. So when patients are sad, we're sad, everybody's sad. Make them happy. That's chin up. Creates a frown line. This one, any major problem? Or is it passable? Just a little bit of chin up, but even just that little bit created a hard palate line that overlaps the roots of the teeth. So again, chin too far up. Here's what it might look like. Here's a nice exaggerated example. Chin way back like this. And I guess I don't talk about it in this lecture. I took it out, but what should be aligned horizontally? In most panoramic machines, in our Plan Mecha ones, is it the ala tragus, which I know a lot of the faculty teach, Or is it the Frankfurt plane? And what the heck is a Frankfurt plane? Nobody knows what it is. That's why everyone remembers ala tragus. It's not the ala tragus. If you have the ala tragus, their chin's going to be up too much. You're going to make them sad, you're going to make me sad, and everybody sad. The Frankfurt plane is the top of the external auditory canal. So if you look at an ear, you can see the hole there, kind of the top of the canal. And then to the bottom of the orbit, kind of think of the top of the cheekbone here. And if that's too hard to do, what I say is make sure that occlusal plane is coming down just a little bit, because that's really the deciding factor. And so look in the patient's mouth, have them smile, have that occlusal plane tilt down a little bit. This one looks like they got some small anatomy, but the over-exaggerated smile line, kind of the Joker smile, is chin too far down. Here's what it might look like. Okay, here's one. Not lined up to the ala tragus, but the Frankfurt plane, you can tell, is even more off. The Frankfurt plane should be coming like this. That chin should be up quite a bit. If you look at it as an occlusion, it's probably coming up about like that. So have that occlusion either level or coming down just a little bit. This is too far. Oh, I do talk about it. Here's the Frankfurt plane. Superior point of the externally auditory canal, or the porion, or to the orbital. What happens to the occlusal plane when you do that? Just a very slight downward angle. That's what I'd like to see in every radiograph. Vertical midline centered, that one's easy. You have a canine line. In the planned Mecham machines, which we have, that canine line should be lined up with the mesial of the canine. And you should look straight at the patient, make sure their head is straight. So make sure they're not rotated one way or the other. You have the little bars that hold the patient in place, which should make this easier. All right, little orange one is one of the giveaways here, but also one thing I failed to point out earlier was, even though I mentioned it, the ghost image of the opposing mandible. Here you see how you have kind of this horizontal area where above here is more opaque, and over here it's right about there. Why is it higher on the right side? Remember, that's the ghost image of the left. It's because the patient's tilted that way. They're tilted with the left side a little higher. That's the ghost image of the left side, and so the ghost image gets projected higher than the ghost image of the opposite side. So that's one way you can tell. Look at the red lines, point out the temporomandibular joints a lot higher on the left side. You can look at the orbits. That's kind of where you're used to seeing an orbit in a panoramic radiograph. In this one, most cases you don't see almost the entire orbit. So the right side is down quite a bit. They were tilted. That's what that would look like. All right, in this case, kind of gave it away with how he looks. Is this right in the center? No. It's off center a bit. His head is rotated a little to the right. Does that make sense with what we're saying here? And this is not too extreme of an example. See how there's not too much overlap? These ones look nice and open. But which teeth look larger, the left or right side? Left side, those look stretched out. They look larger. The right side look narrower. And so you can tell there's rotation. You can look at the midline, and it is off a little bit to the right. So about like he's lined up here. Not super exaggerated, but just a little bit of head rotation. I still see both condyles. So maybe this isn't even bad enough where I would retake it. You want to limit patient dose if you can. If it's still diagnostic, you're okay. I want to talk a little bit about the anterior mandibular teeth here. Why do these roots disappear? Have you seen that before in panos? And what's causing that? That's the focal trough, right? Why are those anterior teeth roots outside of the focal trough? A lot of people have flared anterior incisors. If you think of the maxillary incisors, a mandibular like this. In this case, the maxillary incisors look somewhat vertical because you see the entire root pretty much in focus in the focal trough. But the mandibular incisors are probably back quite a bit. So they probably look like this if you're looking at the patient from the side. What does that do to the roots of the mandibular incisors? They're lying now lingual to the focal trough, and they're going to be out of focus. They're going to be blurred, and a lot of cases, somewhat in this case, not even recognizable. And so that's why you see that a lot. I talk about the anterior, especially the anterior mandible, as being kind of the least diagnostic part of panoramic radiographs. And so you deal with it as you can. Oh, here's a line showing the vertical, and it is just off center 2 to 3 millimeters. So about the same as he's positioned there. All right, what's going on with this one? Here I've shown a gray line right down the center of the image. It looks like the maxillary central incisors are lined up pretty close to the center. Maybe it's off left a little bit. There's a mandibular shift a few millimeters to the left. These teeth are pretty askew. But if you look at the nasal cavity, at least centrally, vertically, this patient was aligned pretty well. That center line goes right through the middle of the nasal cavity. Their teeth just aren't perfectly aligned with their skull. Now let's look at the posterior dentition. Look at those molars. And do they look proportioned similar from one side to the next? Is it symmetric? Or is one side larger than the other? Make sure you're looking at the right molar. Mixed dentition makes it tough, right? So we got a first molar, got a first molar. Which one's larger? That first molar looks wider. This first molar looks wider than the other side. This second molar is wider than that one. So even though the midline is in the center, if I can show that, I was rotated somehow where the back of my head was too far to one side or the other. These ones being widened, here's my left side. This is his right side, so here's my right side. These ones being widened meaning it was closer to the point of rotation. So if I keep my midline in the center, if I rotate that way, now my head is looking right and my right side is closer to the point of rotation. They should be widened. That should be how he was turned. Even though this is in the midline, he was turned a little bit, so he's facing to the right. And we labeled that wrong, but that's okay. Like I said, it's tricky because you have to do that midline. And if the midline's in line, it's going to be opposite what you think. And so the head was turned, in this case, with that right closer to the point of rotation. It was more like this. I would call this my head rotated right. But as long as you can recognize rotation, know that that needs to be fixed. All right, so what's going on in this one? This is the one I mentioned when I was showing that chart with all the different positioning errors, where you see a very pronounced ghost image of the spine. So what causes that? What causes more of the spine to be in the direction of the radiographs? That's when the patient's really slumped. They have the neck kind of curved forward like this. So if the spine is angled back, more of that spine is in the area where there's ghost image. So the x-rays project right through it. And so look at the spine as well on either side of the image. And does that check out? Yeah. Yeah, you see it really curved back like this. And so this may be the first thing you notice. You can verify it looking at the spine there. And yeah, this is the patient slumped. All right, so another example here, you have a really pronounced ghost image of the spine. You don't see the TMJs as well, so that kind of stands out as you're used to now looking all around a pano and seeing what's there. You don't see the inferior borders of the orbits. You can also look at the chin. The chin is up too high. It's positioned too high. And I've seen that in some of our images. So make sure that chin rest is where it should be. So a couple problems with this one. Here's what it looks like when the patient is slumped. Like I said, the neck just projected, curved really far forward. So you get that ghost image of the x-rays going through the spine. All right, here's a case of an error that you can see in almost every panoramic radiograph in the history of man, which is a little airspace between the tongue and the soft palate. So how do we avoid that, or can you avoid that? If you tell the patient just to lift their tongue, you're going to do that, right? Just lift the front of the tongue toward the hard palate and touch it. So you get that air gap. And so what do you tell them? You tell them swallow. Keep your tongue against the roof of your mouth in that position. Breathe through your nose. And if they're able to hold it like that, you eliminate that airway gap between the tongue and the palate. You see it looked good on the left side here. We didn't get that air gap, but on the right side, it's fairly apparent there. And here we see, because his mouth is open, you can see the tongue is not up where it should be. So they should really and they have to swallow to do that, to lift that tongue to the proper position. All right, here's the Joker smile. This is what I mean by the Joker. Way too much chin down. Make your patients happy, but not that happy, right? You cut the TMJs off just from the sheer amount of chin downness that was there. Well, what happens to the hyoid bone when that happens? The hyoid bone then gets projected over the inferior portion of the mandible. What's wrong with this one? This one's a little subtle, but look at the hard palate line, and what was it I said created the error when the hard palate line overlaps the apices of the maxillary teeth? That's from chin up a little bit. Even though the occlusal plane largely looks flat, little bit of a downward curvature right here in the midline, and just a little bit too much. I want to see a little bit of downward inclination of the occlusal plane, so I avoid that error right there. This one, the chin's really down, so much where we cut the chin off, everything's outside of the focal trough. Just looks overall bad, right? Not a great image. You see some of the posterior teeth in focus, but anterior does not look good. All right, so what was this one? Where you really have a pronounced ghost image projecting over the mandibular teeth? What's creating that ghost image? The spine, the hyoid bone, really more the spine. The hyoid bone is relatively small, but this is where the patient's positioned like this, your slumped position, creates that really exaggerated spine ghost image. All right, so that went on a little long, but hopefully gives you a good review of panoramic imaging and helpful to your interpretation of panoramic images, because you have to start knowing anatomy, knowing why you're seeing what you're seeing in a panoramic image. And if you can do that, hopefully you can make sense of things. If you see things that you don't recognize, either study it and look at what it is, see if it might be an anatomical structure. Come to me if you have questions, if you can't recognize things, because you should be able to identify every little object that you see in a pano. Taking advantage of the fact that you can just email me and I'll look at it and hopefully give you a quick answer. But in some cases you may spot something that can affect the patient's life. So do take this seriously. All right, thanks. See you next time.